Welcome, everybody. It's so great to have so many of you here. My name is Sarah Proops. I'm the director of the new Orthodox Union's Emerging Careers Professionals Department, and I'm going to be your moderator today. We are so excited to kick off the first of a four-part series brought to you in partnership with the ECP and jscreen. Today, we're diving into the incredibly important topic of knowledge about cancer screening and how it can help us take care of our health and the health of our families. It's something that affects so many, and we're so grateful to have such an educated team here who are going to educate us from their tremendous experience and their life experience so that we have the tools and the keys to make informed decisions to take care of ourselves and our loved ones. Women's health is such an essential part of the Orthodox community, and it's really important that we know what we have access to practically. It's not just taking care of ourselves, it's so that in Yiras Hashem we're able to take care of everybody we love. I'm so honored to introduce our panelists today. We have Sharon Pollack, certified genetic counselor with background in bioethics. She currently works with jscreen in outreach and social media. Dr. Eliana Fine, physician based in Lakewood at OB-GYN Community Medical Center. She brings extensive experience in women's health and preventative care. And Charlene Aminoff, CEO and founder of Gully Wigs, motivational speaker, Eved Hashem, and cancer warrior, who will be sharing her personal journey and insights on health advocacy with us today. The way this is going to work is everybody's going to present in their area of expertise, and I'm really looking forward to an informative, engaging discussion today. So let's get started. Sharon, starting with you.
All right, I'm going to share my screen. And welcome, everybody. Just want to thank everyone for coming and for everyone who organized tonight's event, especially you, Sarah. Very excited to kick off this partnership. It's very meaningful to us at jscreen, so thank you. Okay, so today we're going to be discussing what you should know about cancer genetic testing, specifically as it pertains to our population. And so let's talk a little bit about what our hereditary cancer testing is. We're going to do a little genetics 101 review. And so all the way to the left, you'll see what a cell can typically look like, right? In the nucleus of the cell, the center of the cell, and in every cell of our body, indeed, we have an identical set of instructions called our DNA. The DNA is essentially a code by which the body grows, develops, and functions. It's a set of instructions. The DNA is condensed onto chromosomes that come in pairs, the little packages of DNA, and we inherit exactly half of our DNA from our mom, exactly half from our dad at the moment of conception. And contained on these chromosomes are different regions of the chromosomes we call genes, and every gene is going to have its own specific function. And so you'll see that all the way on the right. Now, let's talk a little bit about what it means, what the difference between hereditary cancer and what we call sporadic cancer might be, a cancer that occurs sort of by chance is what I would say. And so what cancer essentially is a disease of the genome, a disease of the genetics. And so when we know that there are accumulated mutations, and when I say mutation, what I essentially mean is some sort of genetic misspelling in the sequence of the DNA that shuts down the function of that particular gene. And now what can happen is in sporadic cancer, which you'll see at the top of this slide, is that you'll see that cluster of cells. Those are cells in an individual we would assume would be healthy and well. So you'll notice there aren't any little red marks, but once you see those red marks show up, that represents a gene that has a mutation, is essentially shut down and non-working. And the function of some of our genes is to actually prevent cancer. And so it repairs DNA damage that occurs naturally in the cells, and it avoids the development of cancer. But what can happen is that these mutations can accumulate. Perhaps we'll use the example of BRCA1 or BRCA2. You'll see why in a couple of minutes. But if both of those genes, for instance, so if you'll notate here on this section right here, one knockout of one copy, the next slide, knockout of 2 copies, now we have the potential for cancer to develop. And on the bottom of this slide, you'll notice that this is labeled hereditary. And so what we'll sometimes see with hereditary cancers and families that have predispositions to cancer is that cancers can be more likely to develop, and especially more likely to develop at younger ages. And this is why. Because an individual who actually has a genetic predisposition to cancer, so to say a mutation in a cancer gene, they are born with an existing mutation in one of those genes. And so that means that the likelihood of them developing an additional mutation that then drives cancer growth is actually more likely to happen to them and at a younger age. And so that is why we see the increased incidence of cancer and, again, young diagnoses for individuals who carry mutations that increase their cancer risk. Let's talk a little bit about how these mutations are inherited, how these gene changes are inherited. And we call this form of inheritance autosomal dominant inheritance, which means that a single mutation is sufficient to actually increase the risk for that person. There's a 50-50 chance anytime a person has a child. So they're going to contain, a person who has a mutation has one copy of the gene that's non-working, one copy of the gene that is working. And anytime they have a child, there's a 50-50 chance of them passing that mutation on to their children. We can inherit these mutations from our mothers or our fathers. So males and females will carry these mutations, and they can be passed on to either male or female offspring. And that, I find, is also a very common misconception. So just something we're addressing right there. Let's talk a little bit about cancer risk. So you'll notice in this wheel graph that the vast majority of cancers are what we consider sporadic, so essentially by chance. There's also what we consider familial cancer diagnoses, which is to say that we see there's something serious going on. Many individuals in the family seem to have cancer, but we can't really identify a single gene mutation that seems to be responsible for it. And then in about 5 to 10% of individuals, we actually will be able to identify a specific mutation that increases the risk of cancer. And there's usually red flags for this kind of thing. So we'll see things like many individuals in the family who have been diagnosed with cancer, perhaps they're similar or related cancers. As I mentioned before, frequently there will be a young age of diagnosis. And we also do know that in the Ashkenazi population, there is a vastly increased risk of specific mutations that lead to increased risk of cancer. We'll use the examples of BRCA1 and BRCA2 because they are so common in the Ashkenazi population, and we'll explain in a couple of minutes why that is. But the most important thing to take away is that the increased risk for breast cancers, ovarian cancers are drastically increased over the general population. So where we see about a 12% risk in the general population for breast cancer, you can see that there's up to an 80 some odd risk over the course of a person's lifetime to develop breast cancer in individuals who have these pre-existing mutations. There's also a vastly increased risk of things like ovarian cancer, male breast cancers, prostate cancers in males, as well as pancreatic cancers in both men and women. I'm so sorry, this is frozen. Okay. But I do want to just address as well that it's not just breast cancer that we're most concerned about, and it's also not just BRCA mutations. And so when we see that individuals have increased risk in their family or maybe a family history of things like gastric cancers, colon cancers, uterine cancers, those also can be red flags. We talk a lot about this increased risk of breast cancer specifically, or breast and ovarian cancers showing up in families, but that's not the only pattern we're concerned about. And similarly, when we see families with increased risk of breast cancer, it's also not only BRCA1 and 2 mutations that we're concerned about. There really are very many other gene mutations that can actually increase the risk of breast cancer as well. We'll talk a little bit as well tonight about why these topics tend to be so hot button in the Ashkenazi population and why we're so concerned about this specifically for this population. And that is actually because in the general population, we know that there's about a 1 in 400 risk for an individual to actually carry a mutation within a cancer gene, specifically within the BRCA1 and 2 genes. That number is vastly, vastly increased for individuals of Ashkenazi Jewish descent, a 10-fold risk, in fact, at 1 in 40. And so we'll talk a little bit about why that is and what the implications of that is as well. The mutations that we're most concerned about within BRCA1 and 2 for the Ashkenazi population are due to something called the founder effect. We call them, in fact, founder mutations. And we'll talk about this really quickly. It is a somewhat complicated topic, but the reason that this happens is that a mutation will arise in a population, generally speaking, and then something that is very sort of hallmark of the Ashkenaz population is that we have had marked population decrease, right? Many individuals, let's say, who have been who have left a particular area or were killed, things like migration, self-isolation of our population as well. And so then over generations, we'll actually see this mutation propagate and become more and more common within a very specific population. It's not the only example of this, but BRCA1 and 2 mutations, as far as the founder mutations, are very common in the Ashkenazi population because of this. But something that's really important to note is that that 1 in 40 risk we mentioned earlier is actually regardless of family history. And so that's where we kind of get like a little bit lost, and this turns into a conversation about really like population screening and why that is a really important thing for our population specifically. And so that 1 in 400 risk we see generally versus the 1 in 40 risk is reason enough in the Ashkenaz population. But a misconception we find to occur quite a bit is that individuals think to themselves, well, I don't have a family history of cancer, or I'm only half Ashkenaz, so I'm really actually not at risk. And what it means to be Ashkenazi is to have 1 out of 4 Jewish grandparents. So 25% Ashkenaz is enough for us to consider you Ashkenazi. And as well, even individuals who do not exhibit any signs or symptoms in their family, so family history of breast cancer or personal history of breast cancer, are included in that 1 in 40 statistic. So the question is kind of like, well, why does that happen? Because I'm saying on the one hand, that risk of cancer for these individuals is so vastly increased. And on the other hand, I'm actually saying, well, we might actually miss it in our family. So how does that happen? And there's an answer to that, or we think. And sometimes it's actually because we're seeing a small family size. I'm a good example of actually like, and many individuals of Ashkenazi Jewish descent are loss of family history, right? I had a grandmother who had a breast cancer, but she was nearly a sole survivor. And so all of the family history prior to her really has been lost. And so it's hard to know what might have been going on had there been a larger family. Again, that's an example of limited information, but certainly instances like adoptions or individuals who are estranged from family, or perhaps families that don't communicate about cancer occurrence. Those would be things that could potentially also mean that a person thinks that they don't have a family history of cancer when they actually do. Sometimes families are also predominantly male, and so we'll see that the risks of cancer in individuals who are male are lower, and sometimes those mutations can actually sneak through, especially when multiple generations have been male. I think an important thing to mention here as well, something I used to see clinically a lot, is actually that individuals who think that their families didn't have any instance of cancer, so we'll hear them say things like, oh, that was an individual with lung cancer, might turn out that that was actually a metastasis of a cancer, and that they're not fully informed of exactly what was going on. So it's really important to dig a little deeper than just the surface level as well. And the goal of this sort of testing is not just to scare somebody about their increased risk, but it's really to open doors to take action. And so for individuals who have increased risk of cancer, things like mammograms, MRIs, colonoscopies at increased intervals, so closer together more frequently than the average person, lifestyle changes, so things that can really bring cancer risk down somewhat, are also things that we would want individuals to have the option to sort of take on. Sometimes genetic results can actually also lead to access to targeted cancer treatments or changes in treatment decisions. There's also the option of potentially pursuing risk-reducing surgeries, so actually removing the tissues most at risk for developing cancer. And it also opens up the doors to reproductive options, so individuals actually stopping that chain by influencing what the next generation will ultimately inherit, which is a bigger topic for another time. At jscreen, our mission really is to empower the patient and make sure that this testing is accessible by patient-initiated care. So we want to make sure that our followership and that the people that we're reaching are able and empowered to access this testing on their own. If you've tried to get genetic testing through your doctor, you might have noticed that it's not always so simple. Not every doctor is going to be willing to offer the testing, knows how to order the testing, knows what to do with the results. And jscreen is removing that barrier by, again, allowing you to access this testing, allowing access to a physician ordering service, and on the tail end, when the results are available, offering you genetic counseling so that you're not alone in the process, and you make sure you know exactly what to do with the results. We offer access to reproductive carrier screening and hereditary cancer testing, but of course, we're talking mostly about hereditary cancer testing tonight. And some of the things you might be able to expect as far as the process is that you request a kit online at jscreen.org. Anyone visiting the website that's been on the webinar tonight and at future webinars can use the code OUECP for a discount off of the jscreen fee. You'll receive a saliva kit by mail. It comes in like a little kit envelope. All you have to do is spit a little bit into a tube. It's a much bigger tube than the actual amount of spit that you have to give. It's really, really a tiny amount. It's remarkable, but the DNA there is identical to all the other DNA in your body, and we can test that sample. And then you return it in the prepaid mailer, and ultimately you'll get your results by telehealth. Something that we hear as a concern fairly frequently is just what it looks like to keep that information private, which is a very understandable concern. But because we are utilizing sort of the gold standard of laboratories, Myriad Laboratories, and of course, like jscreen is compliant with HIPAA and all privacy laws. So it really is an understandable concern, but one that we are very sensitive to. Frequently, we get a lot of questions about how much this would cost. There is a $49 upfront fee, but again, discounted tonight for anyone who is seeing this webinar, and ultimately will attend events post this webinar. Again, there is the option of doing what we call self-pay, which caps the cost at $249. But more people then realize that are actually eligible for coverage by their insurances if they meet certain criteria. Being Ashkenazi is one of them, and having pretty much any history of cancer, as far as breast, ovarian, pancreatic, prostate cancer in the family, does help a person meet criteria. Frequently, that person will have no additional out-of-pocket costs. We'll take questions at the end, but happy to receive them now if you'd like to enter them into the Q&A box. And I'm going to stop sharing and hand it back over to Sarah. Thank you so much.
Wow, Sharon, so much information, but information and knowledge is power. And what you at jscreen do, making testing available to the masses, is really, really tremendous. We're so excited that after this webinar, there are going to be local testings, as well as we're going to be able to order online with our promo code to get those tests shipped to you directly. Thank you so much for sharing your knowledge and expertise with us. Dr. Eliana Fine, I'm so excited to welcome you to hear more about what cancer screening looks like in practice. Thank you.
Hi, everyone. So here for the objectives. So number one, we want to understand the evidence-based breast and ovarian cancer screening recommendations for women, and this is average risk women. We want to review what to expect during common screening tests, explore how genetic results personalize cancer prevention and fertility planning, and we want to empower women to advocate for proactive health care. A woman's lifetime risk of developing breast cancer is approximately 12%, which was covered during the other presentation. 1 in 8 women will develop breast cancer. So if you are in a group of women and there, let's say, are 16 people there, according to the statistics, 2 of them will eventually develop breast cancer, which just shows us how important it is to be able to screen for it properly. So some risk factors for breast cancer that are important to know, we'll kind of go through them on the slide. You can read along. So number 1 is if you have a family history of breast cancer or a mutation, if you have prior breast biopsies with specific pathology, if you got your first period super early, if you went through menopause much later on in your lifetime. The average age of menopause is between 51 and 52. If you've never had children before, if you have a prolonged interval from the time, if you've ever been on menopausal hormone therapy, if you've never breastfed, the older you are, the more at risk you are of developing any sort of cancer. Certain ethnicities, like Ashkenazi Jewish women, if someone has a higher BMI, if someone consumes a lot of alcohol, if they smoke, if they have dense breasts on mammograms, and if they have a prior exposure to radiation for treatments of other cancers when they were younger. So for anyone here who has had mammograms recently, there's a new guideline where all of the mammograms will tell you whether or not your breasts are dense. Women with dense breasts that are diagnosed by mammography have an increased risk of breast cancer, and that has to do with the reduced sensitivity to detect breast cancer in those women with dense breasts. A lot of times, an extra ultrasound and on top of a mammogram would be recommended. And then the goal of breast cancer screening is threefold. So number 1, you want to detect preclinical disease in healthy asymptomatic patients. You want the goal of the screening to help improve survival And you also want to help avoid the need for more intensive treatments. And so there's different recommendations for breast cancer screening in the average age woman. And this has to do with the different guidelines out there. So as an OB-GYN, I follow the American College of Obstetricians and Gynecologists. Other name for that is called ACOG. And so we recommend doing clinical breast exams every 1 to 3 years, starting at age 25, and then definitely annually for women age 40. We also start offering mammograms yearly at age 40. And then in terms of stopping, we stop based off of shared decision making between the provider and the patient based off of life expectancy and other comorbid conditions that the patient has. And this discussion is usually held around age 75. In terms of mammography, it's important to know that it does decrease breast cancer mortality. And so, depending on how old you are when you start breast screening with mammography, that can reduce your risk of potentially dying of breast cancer. Some adverse consequences of mammography are number one, if there's a false positive result, a lot of times that can lead to follow-up biopsies. Obviously, it could be anxiety and um, can cause a lot of distress in patients. There's some patients that develop a lot of discomfort during mammography. We can also overdiagnose, and that occurs when screening detects cancer that would not have progressed to symptomatic cancer if it was left undetected. And then overtreatment, which is the initiation of treatment for an overdiagnosed cancer, in addition to the radiation exposure associated with mammography. In general, it's always a good idea to be able to understand the risks and benefits of any sort of intervention that your physician offers. And with regards to the radiation exposure, even if a woman is pregnant, it is still recommended that they undergo breast cancer screening since the risks of radiation exposure due to the mammography are very, very low. So a recent modeling study estimated that the potential mortality benefit of early breast cancer detection through annual screening starting at age 40 definitely outweighed the risks of dying from any sort of mammography radiation-induced cancer. This is definitely an important fact to know if you are someone that is afraid of the radiation exposure. In this study, radiation from annual screening of 100,000 women between the ages of 40 and 74 were estimated to induce 125 cases of breast cancer and 16 cases of breast cancer deaths. And this is compared to 968 cases of cancer deaths that were prevented by the early detection through the screening. So mammography is safe and is one of the best tests we have. In terms of understanding what type of breast cancer risk assessment tools are out there, I'm going to go through a few of them. So women with a potentially increased risk of breast cancer based on their history should have further risk assessment with validated tools. Risk assessment in general should be used to identify women who can benefit from different tools to prevent breast cancer. So number one, we have genetic counseling. Number two, we have breast MRIs, which is an additional screening modality, more frequent clinical breast exams. And then number four is that risk reducing strategies can be offered, like chemotherapy, mastectomy, etc. So one of the popular models that we use is called the Gale model. I did screenshot on the side what it looks like when we fill in your information. And there's a website called mdcalc.com that is a free website anyone can utilize. And there's a lot of different calculators out there. You can choose a Gale model for breast cancer risk, and that just show up. And you can even plug it in for yourself to understand your risk. So this helps to determine the absolute 5-year risk and lifetime risk of developing breast cancer for an individual. Patients who have a 5-year risk of greater than 1.7% of developing cancer are candidates for chemoprevention. That means receiving chemotherapy before they would have developed cancer to help prevent them from developing cancer. For this, you would have to be referred to a breast surgeon. The one downside of this specific model is that you do have to be 35 years and older to be able to utilize it, since that's what the test is validated for with regards to which population. And then there's the Trier-Cusick model for breast cancer risk evaluation, which is an excellent model. I recommend everybody write down the URL to this calculator. You can even Google it and find it online. It's called IBIS.IKONOPEDIA.com. And this helps to determine the likelihood of a woman developing breast cancer within 10 years of her current age and over the course of her lifetime. This also takes into account their breast density, and that would be noted on a mammography. In general, radiologists do type this score in all radiology reports when they are diagnosing a mammogram, and so your score will be written on there, but it's important to understand your risk and what risk factors you may have, and this can potentially cause you to want to see a genetic counselor or talk to your OB-GYN or be referred to a breast surgeon to understand your risks a little bit further. And so we recommend what is called breast self-awareness. Breast self-awareness means being familiar with how your breasts normally look and feel. So if something changes, you'll notice it early. It's not about doing a formal self-exam on a set schedule, but it's about knowing what your baseline is. It's important to understand that you should notify your OB-GYN if you notice any changes to your breast, such as pain, a mass, nipple discharge, skin dimpling, nipple retraction, or redness. Approximately 50% of cases of breast cancer in women 50 years and older, and 71% of cases of breast cancer in women younger than 50 years are detected by women themselves. So this is definitely huge. Women at average risks of breast cancer should continue screening through at least age 75. After 75, the decision to discontinue is based off of sheer decision making. This is informed by the woman's health status and their longevity. Per ACS, which is another guideline that we have, women should continue screening as long as their overall health is good and they have a life expectancy of 10 years or longer. In terms of understanding how beneficial mammography is in that population is a little bit difficult since most of the studies had a cutoff of the age 74, so we don't really know in terms of how well mammography is in detecting breast cancer and improving survival in that population. But as you age, you are at increased risk of developing breast cancer. So if you don't have many comorbidities, it is something to consider. And then I do want to talk about hormonal contraception and breast cancer risk. Women who use birth control have a small increased risk of breast cancer, but the overall risk of breast cancer in hormonal birth control users remains very, very low. Hormonal birth control is very effective in preventing pregnancy and can lower a woman's overall risk of cancer by providing protection against other types of cancers. And we're going to talk about that later on. Women can do other things to help lower their risk of breast cancer, like breastfeeding, getting more exercise, limiting alcohol use. All of that can be more beneficial to help reduce your potential risk than deciding not to go on birth control. It's something to understand and to know about, but definitely even in women who do have a family history of breast cancer, who carry certain breast cancer mutations, utilizing hormonal birth control is still an option for them. It's not a contraindication, and we're going to talk a little bit about that later on. So in general, for average risk women, annual breast exams, annual mammograms starting at age 40, that is what is definitely recommended per ACOG. This is what typically most OB-GYNs will recommend. And then if someone is high risk, meaning that the risk of developing cancer is much greater than the average risk woman. Annual or biannual breast exams, meaning you're going to come in once a year or twice a year for a breast exam. You'll likely get annual breast MRIs as well as mammographies, and this typically starts at age 30, sometimes a little bit younger, depending on when family members developed breast cancer. And now we're going to move on over to ovarian cancer and focus on that. So ovarian cancer is the second most common type of female reproductive cancer. More women die from ovarian cancer than cervical cancer and uterine cancer combined. Unfortunately, there is no strategy for early detection of ovarian cancer that reduces ovarian cancer mortality. There can be potential harms from invasive diagnostic testing that results from having a false positive test result. It's important to evaluate someone for ovarian cancer based off of their signs and symptoms. An appropriate level of suspicion should be maintained when signs and symptoms of ovarian cancer are present. So if anybody has an increase in abdominal size or bloating, or pelvic pain or abdominal pain, they have difficulty eating or feeling full very quickly, those are definitely some potential warning signs. Although these symptoms are common in women with ovarian cancer, the vast majority of women with these symptoms will not have ovarian cancer. And that's because a lot of the times these are vague symptoms that can be caused by so many other conditions. It's just important to bring this up to your OB-GYN. Just like with breast cancer, a lot of women self-detect it. Same thing with ovarian cancer. So I want to talk about hormonal contraception and ovarian cancer risk. So women who have used any sort of oral contraceptives, and this is specifically with estrogen, progesterone pills, they actually have a 30 to 50% lower risk of ovarian cancer. The longer oral combined contraceptives are used, the greater the protective effect against ovarian cancer. This protection can last for up to 30 years, even after you stop them. 1 year of birth control use can reduce your risk of ovarian cancer by 30 to 80% in patients who have BRCA, and about 58 to 63% in patients that have BRCA2. And many OB-GYNs prescribe birth control pills to patients that carry BRCA mutations as a way to help lower their ovarian cancer risk, especially in women who aren't ready to undergo other surgeries that can reduce their risk even lower. And those would be surgeries to remove your fallopian tubes and ovaries. In terms of having genetic testing and personalized screening, it's important to know some symptoms out there that can increase your risk of developing a gynecological cancer. So we have the BRCA genes, we have Lynch, P10, TP53, PALB2, and CHEK2. So once you get genetic tested, these results can help guide future management. So number one, you can have earlier and more frequent screenings. You can choose to undergo risk-reducing surgeries, such as removing your breast tissue, that's called a mastectomy, or removing both of your ovaries, that's called an oophorectomy, or removing your fallopian tubes, and that's called a salpingectomy. There are reproductive decisions that you may have to make once you get tested and find out that you carry a mutation. And this would be to undergo in vitro fertilization with PGTM, which stands for preimplantation genetic testing for monogenetic disorders. So what that means is that instead of getting pregnant naturally, you would go to a specific physician called an REI or infertility specialist, and they would remove your ovaries, not your ovaries, they're going to remove eggs from your ovaries, and then they take sperm from your spouse or your partner, and then they mix it together in a laboratory and they test the embryos for the specific gene that you have inherited that could potentially increase your child's risk of developing cancer. And then if they see that this embryo let's use BRCA since that's a very well-known one. So if they see that that embryo carries a BRCA mutation, they're not going to implant that for you. There's no way to, at this point in technology, change the genes of an embryo, where if an embryo has BRCA, you can't like change that fact. But if you don't place an embryo with BRCA into a woman for them to get pregnant with, then they're not going to have a baby that has BRCA. They can have other embryos implanted that do not have the BRCA gene. And then fertility preservation discussions before surgery or chemotherapy is definitely important to have. In general, there is some data out there that does show that women who carry the BRCA mutation, some of the studies show BRCA1 over BRCA2, but definitely with BRCA in general, it can potentially cause what's called diminished ovarian reserve, which means that it could essentially decrease your fertility. And so sometimes having that information in advance, and if you are someone that does not yet have children, or you're not ready to have children yet, or you don't have a partner yet, but you want to have children in the future, you can definitely consider doing fertility preservation to assist you in terms of getting pregnant in the future.
We're so grateful to you for your time in going through that with us. Without any further ado, it is a zchut for us here to hear from Charlene Aminoff, her survivor story, her journey with breast cancer, and the power of genetic testing and how truly it saves lives. Charlene, thank you for being here. Thank you for being open to share with us. And we're all looking forward to hearing from you.
My greatest zechut, my greatest pleasure. So I'm going to just pour my heart out and let everybody who's listening know that had I not gone for my routine mammogram, I don't know where I would be right now. I'm 44 years old. My name is Charlene Aminoff. I'm Baruch Hashem blessed with 5 children. And I had always been, since I turned 40, super diligent about mammograms, pap smears, blood work. I never left any stone unturned. I had all of my appointments always made. From my last appointment, I would stand by checkout and already schedule myself for the next appointment. It's incredible to know that making sure I had my mammogram scheduled on my calendar way before I needed to was probably Hashem's way of letting me find my cancer way before I became symptomatic. I went for a routine mammogram, Erev Hanukkah, and I didn't feel anything. I have zero family history of breast cancer. My mother is a non-Hodgkin's lymphoma survivor, but no correlation to the breast cancer. And I went for a routine mammogram, Erev Hanukkah, waited for my results, did not hear anything for about 2 weeks. And I was down in Miami vacationing with my family in the Altair, my favorite hotel in Florida. And I suddenly got a phone call from the radiologist. And I see on my phone, Yosef, I love you, thank you. And I got a phone call from the radiologist, and I'm at breakfast with my entire family. I answer my phone on speaker, and the radiologist says in a very cool, almost robotic tone, "Hi, Charlene, it's Dr. So-and-so from radiology. So I have your biopsy results over here. And yeah, you do have breast cancer. Do you have the phone number of a breast surgeon, or would you like me to provide you with one?" And I was like, what? What is happening? What does that mean? And I'm like, one minute. Rewind. So I was there 2 weeks ago. You guys saw something. I happen to have dense breasts. And because I have dense breasts, I always have to do a mammogram and an ultrasound afterwards. And I noticed a technician sped through the right side, but she really took her time on the left side during the sonogram. And they had to redo the mammogram and redo the sonogram, and something was going on. They did a needle biopsy right away, told me, "We see something, we're not sure what it is, but don't worry, it's probably going to be nothing. You just have dense breast tissue." And then fast forward 2 weeks later, I get this call with my entire family, and my walls came crashing in. And zero sympathy. So if there are any radiologists out there, let this be your message. Report the results with a little bit more compassion. And my world was spinning, and I said, no, I will find someone. And really, the rest is history. Baruch Hashem, I linked up with RCCS, Hodul Hashem. They were so instrumental in just pointing me in the right direction because my brain had ceased to work. I was like in a fog. I didn't really understand what was happening. And I still had so much trauma from my mother's diagnosis. My mother was diagnosed stage 4 non-Hodgkin's lymphoma right after my daughter Gali survived drowning. So that was a very intense year. And automatically I started thinking, I'm 43. I'm healthy. I didn't feel anything. This was routine. What is going on? Baruch Hashem, Hodu Ladonai Ki Tov Ki L'Olam Chasto. I right away got set up with an amazing breast surgeon. I went for an MRI, Chazdei Hashem, no new findings. I was scheduled immediately for a lumpectomy, and we did not know anything else about my genetic testing, my oncotype. I did not know if I would need chemotherapy. I did not know what my treatment plan looked like. All I knew is that Hashem is telling me, okay, I have to go in for a lumpectomy, and we'll take it from there. So comes the day of my surgery. I'm getting prepped to go in. And I remember learning, I do these video messages for kosher.com called Shabbat Shmooze. And in one of my Shabbat Shmooze episodes, I talk about Yosef HaTzadik being called an Ish Matzliach, which means a successful man. And he had beautiful mazel. So Chazal ask, what made him Matzliach? What made him so successful? And it calls him a Gever Kafuz. Gever Kafuz has two meanings. It means either a restrained man, that he would hold back with the temptations of Potiphar's wife, but Gever Kafuz also means a dancing man. He danced. And because he danced, he raised his mazel. So as I walked into surgery, I danced. I didn't walk in, I danced into surgery, and I forced every person in that room. It was a surgeon, I think a backup surgeon, an anesthesiologist, 2 or 3 nurses, all in the room. I said, every single one of you will get up and dance because we need to raise the mazel in this room. And it was so empowering to know that Hashem allowed me to find it before it found me. And Chazdei Hashem, I had my lumpectomy. They sent off the pathology. It took 2 weeks until all the genetic testing came back and my oncotype came back. And Baruch Hashem, Hodul Adonai Ki Tov Ki L'Olam Chasto, my tumor would not have benefited from chemo. So I just needed 15 rounds of radiation, and I will be on this lovely, lovely drug called tamoxifen for 7 years because I was so young upon diagnosis. They want to put me into chemical menopause until I'm 50 years old. So I saw right away from this that knowledge is power. We as women, we have bina, we have intuition. We know we need to go take care of our health because we're busy. We've got so much going on. I have 5 kids, Baruch Hashem. I run a few businesses. I was telling my breast surgeon, I was telling Dr. Karen Kostroff, I don't have time for cancer. And she was cracking up. She's like, well, you have to make time for this. We need to be cognizant of the power that lies within our abilities. If we are diligent with our mammograms and pap smears and everything, we can nip it in the bud. Listen, we can't avoid cancer. We really can't. But if we find it early enough, breast cancer is not just treatable, it is 100% curable. So I'm so grateful to Hashem that when my genetic testing came back, every single thing across the board was negative. And I kept thinking, like, Hashem, you're just paving this entire journey with so much love and kindness. There's no way around it. Cancer stinks, completely stinks. There's a lot of stronger words I could use for it as well. But we have so many tools at our disposal to help discover it early on so that we can avoid the harsh, intense treatments like chemotherapy or mastectomies. I was very lucky. I was very lucky that I had invasive ductal carcinoma, stage 1. Chas v'shalom, if my tumor had been just a little bit larger, it would have already, God forbid, been considered stage 2, and then it would have changed the landscape. So early detection saves lives. And this is why I was so passionate and so gung-ho to speak when jscreen reached out. I said, Na'asa v'nishma. I went public. with my journey and my diagnosis, because I know that Chazal tell us when you save one life, it's as if you saved an entire universe. I found out after I got, as of about a week ago, 32 women who follow me, who are in my world, found out they had either DCIS stage 0 or stage 1 way before they were even due for a mammogram. I feel like Hashem chose me so brilliantly and so properly because he knew that I would use my platform, use my audience, use my mouth, and spread awareness and have women go and get checked. Those 32 women are 32 universes that my neshama is zochet to have saved. So although everything about cancer stinks, there's nothing fun about it. I still have my war wounds. I got my radiation burns that I will have my badges of honor until Mashiach comes. But knowledge is power. We need to get tested. We need to get screened. We need to go checked early before we become symptomatic to just avoid it becoming a Category 5 hurricane.
Wow, incredible. You shared so much, Sharon. You shared so much. If there's one powerful insight that you want to share with everybody listening today, something empowering and something that you want everyone to leave this webinar with, Sharon, we'll start with you. What would you say? What would you say the one thing you want to leave everybody with, the message today?
I think that one main message I always try to get across to patients or anyone who asks me sort of any questions about genetic testing is really just to think about yourself as sort of like the most important person and the main character in your own life, and anything you can do to help yourself live a long, happy, and healthy life is the thing you should do, regardless of sort of judgment or stigma or fear. Honestly, think about yourself as like the most important thing to you.
Beautiful. Charlene, what would you say?
You know, it's interesting because there's such taboo. Genetic testing is a little taboo, and especially in the frum community, it's a little bit taboo. And I think one of the biggest barriers is fear. Fear of what if I find out something bad? But what we don't always realize is that not knowing does not protect us. It just gives fear more power. Knowledge is power. Knowledge is action. When a woman takes that brave step to get tested or screened, she's not just protecting herself, she's protecting her children, her sisters, her nieces, generations after her. And in the frum community, there's also this cultural hesitation of feeling like, I don't want to know. Ignorance is bliss. Or even one step further, it's Hashem will take care of it. Guys, I am the queen of Emunah. Yes, of course, Hashem will take care of it. But going for screening isn't a lack of Emunah. It's actually an expression of it. You're saying, Hashem, I'm doing my hishtadlut, my part, because I value the gift of life you have blessed me with. So I tell women, don't think of screening as scary. Think of it as empowering. You deserve to know. You deserve to live ad meva esrim. And when we do it together, when women support each other, the fear really melts into courage.
Beautiful. Really, this has been informative, it's been uplifting, it's been empowering. I'd say often when we talk about cancer and people are scared of saying the word, what's so significant about what we've learned tonight is that it's not that we respond when we hear negative news. We have the capacity to take preventative measures to take care of our health before we get to a situation of a chas v'shalom situation. So Charlene, really hearing that you've literally saved so many lives by sharing your story. We feel so blessed that you've taken the time to share that story with us today. Sharon, thank you so much for all jscreen.
Sarah, before we sign off, I just got one of my followers just sent me a message. She's on the webinar, but she sent me a DM. Can I read her question?
Please.
Okay. She said, what advice would you give me? What advice would you give women who wants to start an uncomfortable conversation about genetic testing with the spouse, parents, or children? Because talking about cancer risk or genetic testing with family can be a little bit difficult. So what I have to say about that is that these conversations really can be a little bit sensitive because they touch on both love and fear. But my advice is start from a place of connection, not correction. You're not saying you have to go get tested. Instead, you have to say, I care about you so much and I want us to stay healthy together. Normalize it. The same way we get our kids vaccinated or we check our mezuzot in our home, it's not about panic, it's about partnership. Hashem and you're getting tested. It's Bezrat Hashem to allow you to live a longer, healthier life with those around you. Don't do it out of panic. Do it benachat, in a kind and easy way, and just connect, normalize it.
Communication and education is key. What's really exciting also to leave this webinar with is we're not just talking about the education, we're not just sharing, Charlene's not just sharing her personal narrative, we're going to be having in-person screenings in locations. So look out for the follow-up information about in-person screenings, as well as you heard from Sharon, you can order online with the promo code OUECP for a discount to have the hereditary cancer screening kits and genetic testing kits sent to your home. We are so blessed to have jscreen, who are really at the forefront of all types of screenings and educations for our community. And Charlene, thank you for being such an advocate for MS, for truth, for connection to Hashem, to community, and being a light to so many. And like you said, literally saving lives, practically as well as spiritually.
Hashem.
Thank you to
so
everybody
much.
for coming. And keep a lookout for information on screenings, both in person and that are going to come to you by mail for those that wish. Thank you, everybody. Thank you for joining us.
Bye. Thank you. Hatzlacha.